finishing up this lecture with the most important condition of all. You tend to get the most amount of questions on this on any test, and it is TB. So you should be on a page that looks just like this. It was right after the emphysema page. It talks about guidelines for PPDs. Now we're going to talk a lot about PPDs. First off, you've got to remember that PPD is purified protein derivative. That's what it stands for. Purified protein derivative. Another name for the PPD is called the MAN2. Okay, so you have to know both names. This is a screening, not a diagnostic. This is a screening test for TB. And you have a couple things to remember about this test. It's an intradermal injection. An intradermal injection. We have to use a 27 gauge needle. 27 gauge needle. That's huge. And when we do this intradermal injection with the 27 gauge needle, we must use a 10-degree angle. And we need to read it 48 to 72 hours later. You will see the 48 to 72 hours later right on your handout. 48 to 72 hours later. And again, it's an intradermal injection. Now, here's where we get a little complicated and where people totally screw this up. And there are so many ways to mess up TB on the test. So, here we go. You, the nurse, have just given the patient an intradermal injection for a PPD test for screening for TB. You used a 10-degree angle with the 27 gauge needle. You injected this, this purified protein derivative into the patient, and you are going to read it 48 to 72 hours later. When you go to read it, you are looking, and it is right up under your heading, on the same handout under positive findings, you are looking for the degree of induration, like it says on your handout, and the amount of swelling, and you are measuring it. So you are measuring the swelling size. You are not measuring the redness. So you are looking at degree of induration and swelling size. And if it's positive, you already know the next step is a chest X-ray. Now, here's where we get into trouble. There are 3 contraindications to getting a PPD, one of which no one ever knows, so they keep doing PPDs on patients born outside of the United States, totally screwing everything up. So let's give you the 3 contraindications to a MAN2 PPD test. And some people call it the skin test, right? Here's some of your contraindications. Number 1, if you've had a positive PPD in the past, you cannot get another PPD ever in your life. So that's number 1. Number 2, if you've ever had tuberculosis in the past, you will never get another PPD ever again in your life. Number 3, and this is what everybody's going to forget, if you are born outside of the United States and you have had a positive BCG vaccine. And I'm going to write that BCG vaccine right here because most of you didn't know anything about it. So BCG, Bacille, Calmette, Guerin vaccine. If the patient has been born outside of the United States, specifically, and that's not for all patients, but specifically if they were born on the continents, notice I didn't say country, I said continents. If they were born on the continent of Europe, Asia, or Africa. I just gave you continents and threw you a curveball because you don't know your geography, but that's okay. Just stay with me. Africa, Asia, or Europe, any one of those three continents, they automatically get a BCG vaccine as part of their routine vaccinations as a child. So if this patient has gotten a vaccine in another country, they do not qualify for a PPD. The reason why you don't want to give this patient a PPD vaccine is because this is a live vaccine. And because it's a live vaccine, you will cause a false positive result. In other words, it'll look like the patient is positive and they're not. I cannot tell you how many students I have, and maybe you're one of them, where you were born outside of the United States on one of those three continents. Some idiot gave you a PPD for nursing school. It turned up positive. They made you take medication that you didn't even need, not to mention that x-ray that they ordered, and you were fine. The whole time you were fine. It's crazy, but because they were just not, they didn't know, they didn't have the knowledge. You have the knowledge, so don't go and do dumb stuff, okay? So let's take it back. You're gonna hear me repeat everything I said over and over again, because I want you to get it. Boom. Your patient comes in, they need a TB screen. You have pulled out the purified protein derivative MAN2 test. You have pulled it up in a syringe with a 27 gauge needle. You have injected it, and you have used a 10-degree angle to do that. You have given her an intradermal injection. You told her she needs to come back and have it read in 48 to 72 hours. You checked before you gave her that shot that she never had TB, she never had a previous positive PPD, and she sure as hell didn't have a BCG vaccine in another country. You made sure all of that was met. She came back, you read it, and you checked it, and you measured it for the degree of induration and the size of the swelling. You noticed that it was positive. Because it was positive, you know that that means that the patient has positive exposure. Yes, you have to write this down. This is a positive exposure. Now, the next step is to send her to chest x-ray to check for active disease. This patient goes to get a chest x-ray. The chest x-ray is negative. Should the patient be treated? Yes or no? I can't hear your answer. I'm assuming 99.99% of you said no, because that's what I get when I go around the class and ask you, and you would be wrong. It's the most common question missed. Yes, the patient needs to be treated. So we're going to treat this patient, and we're going to treat the patient for something called latent TB. Let me be real clear. Positive PPD means the patient has been exposed. They go get a chest x-ray, and even if that chest x-ray is negative, they still need to be treated. Their diagnosis is latent, not late, latent TB. We are treating them to prevent active disease. They are not contagious, but they are absolutely exposed. They absolutely need treatment. We are going to treat them with two medications, INH and rifampin or rifapentine. Specifically, rifapentine is better. So if we give them INH, which is isoniazide, INH, and rifapentine, then we will only need to treat them for 3 months. And of course, we have to add B6 vitamin supplements, because anytime a patient is on INH, which is isoniazide, if the patient is on INH, they're going to have decreased absorption of pyridoxine, which is vitamin B6, and that is going to lead to neuropathies. Now, you have a handout that says all that on it, so we're not going to, go crazy with, I can't write that fast, because you already have a handout with a lot of this on it. So, again, watch me say the same shit, different day. You have a patient who came in for a TB screen. You went ahead and pulled out a MAN2 purified protein derivative injection with a 27 gauge needle. You injected it at a 10-degree angle, and you gave an intradermal injection. You instructed the patient to come back and have that read in 48 to 72 hours. You made sure before you gave them the injection that they had never had TB, they never had a positive PPD, and they had not been born in another country where the BCG vaccine was given. After injecting the patient, you gave them the instructions to return in 48 to 72 hours. When they came back, you went ahead and evaluated and measured for the degree of induration and the size of the swelling. Based on that, you said they were positive. They have a positive exposure. They went for a chest x-ray, and let's switch up the game right here. When they went for a chest x-ray, instead of coming back negative, this patient, while in the chest x-ray, they saw positive cavitations, which means lesions in the lungs, which means active disease. So now we have a patient who is positive on the chest x-ray. Positive cavitations have been seen. Typically, this patient is quite symptomatic, so this patient needs to be isolated immediately. So your first nursing action is private room. In other words, isolate this patient yesterday. Get them away from everybody else, and damn sure get them out of radiology before they make somebody sick. So put them in a room all by themselves, okay? Now, with this patient who now has active disease, I want you to turn the page, and you will see a page where the patient is sitting on an exam bed, and they're very sick, and they have the typical flu-like symptoms on the left-hand side of the page. If you look on it, it says malaise, it says weight loss, anorexia, fatigue. They have a low-grade fever. They have night sweats at home, at night in bed, night sweats. They may, if they're very, very, very sick, they may have something called hemoptysis. And you want to kind of write that down. It's on your page there, the active TB page. They may have hemoptysis. Hemoptysis means coughing up blood. Hemoptysis. They will have a low-grade fever that gets a little bit higher at night. This is called active disease, active TB. So if you look on my board, that's this one, okay? Active TB, all right? Now, this patient is going to need 4 medications. But before we get with, going with all that, what kind of patient is this? Who is actually at risk for TB? Well, I want you to make a select all list. The patients who are high risk for TB include prisoners, homeless, nursing home or long-term care facility patients, IV drug use, healthcare workers, recent immigrant or foreign-born patients, patients that have end-stage renal disease or immunosuppression like cancer patients. But the number 1 patient at risk for TB is the HIV positive patient. Okay. Now, you have a couple things at the bottom of this page where he's sitting on the exam bed. You have a couple things at the bottom. The patient needs a sputum culture. Please don't make the mistake of thinking that the chest x-ray is diagnostic. It's not. The sputum culture is diagnostic for TB and it's diagnostic for pneumonia. So the sputum culture must be done. We are checking for something called Mycobacterium, which is acid fast bacilli. It's a gram-positive acid fast bacilli. You absolutely have to know acid fast bacilli, okay? That is what we're doing the sputum culture for. In order to determine whether or not this patient is still contagious down the road after treatment, we're actually going to need 3 sputum cultures in a row to be negative to call this patient no longer contagious. But right now, they're super contagious. And in order to say they're not, you're going to need 3 negative sputum cultures in a row. On average, this is going to take about 2 to 3 months for them to get to that point. Okay, so that's a big deal. Now, this patient, if you look at the handout, they're going to be on a lot of different medications, and it's 4 medications, and we, depending on how high risk the patient is, because we do not want TB to be a significant public health issue in the United States, and we have been lucky, it is not a significant public health issue, but in order to make sure it's not, we have something called DOT, direct observation therapy. This is for high-risk clients like our homeless patients, IV drug use, you know, patients that we know may not do the right thing because of their circumstances in life. Direct observation therapy is that the nurse is going to watch them take these 4 medications, or their family member who says they're going to be responsible for them is going to watch them literally take this medication and make sure and sign off on the fact that they're taking this medication, because it is that serious that we make sure the patient does that. If you turn the page backwards, I think you will see, I'm pretty sure if you go backwards, maybe it's frontwards. Let me see here. Yeah, it's backwards. 1 page back, you'll see the INH, or the isoniazid handout. This is just one of the 4 medications that this patient's going to be treated with. Keep in mind that it is also the same medication that we use for latent TB. So both latent and active TB are going to take INH, but that's the only thing they take that's the same. So isoniazid, which is INH, I'm going to give you a select all list of instructions about how to take this and what to remember about this medicine. Number 1 is taken on an empty stomach, first thing in the morning. All TB medications are toxic to the liver, every single one of them. So you have to do we have to do liver function test first. Okay, liver function test first. We want the patient to know they cannot drink any alcohol, because alcohol and TB meds will kill the liver. We want the patient to be taught to monitor for yellow sclera and jaundice skin. So yellow sclera, jaundice skin, monitor for any bruising or bleeding. Because INH, or isoniazid, decreases the vitamin B6 absorption, we have got to make sure we tell the patient to buy over-the-counter B6 supplements. They will prevent the patient from getting neuropathy, because if you don't tell them that, they're going to get some painful neuropathies in their extremities. So they're going to be numb, tingling, and have pain if we're not careful. The other thing with this is if it's a young lady and they're on birth control pills, they need a backup birth control method because it can decrease the absorption of the birth control medication. And that's only basically patients on the pill that you have to worry about that with. If you look at that handout, it talks about the liver function test. It talks about the jaundice. And it talks about B6 deficiency and no alcohol. So everything you need is right on that handout for that medication. So we know that the patient that has active TB, we know isoniazid is going to be one of their medications. How do we remember all 4 of those medications? We use the mnemonic of right. So if you turn to the page, keep turning till you get to the page that has TB medications, you will absolutely see right. And the R is rifampin. Rifampin, if you can color, make it orange or red, is going to turn all bodily fluids orange. Tears, sweat, saliva, everything's going to be orange. And when it comes to contact lenses, the fluid around the eye will be orange and it can stain the contact lenses. Everything's going to turn orange. So that's actually normal, right? And then isoniazid, which is your INH. We just talked about that medicine. And then you have what we call PZA or pyrazinamide. For this one, you want to put push fluids because it does increase the uric acid. So PZA will increase uric acid, can cause like gout or whatever. So push fluids with that one. And that medicine is only taken for a couple of months. And then you see something called ethambutol. Ethambutol. Ethambutol is a medication that we use, the 4th medication. The whole reason why we use it is to prevent TB from becoming resistant. So if you use all 4 of these medications, you will prevent TB from becoming resistant. That is something you had to know for test questions. Why do we use so many medications? Because we want to keep confusing the disease. Now this ethambutol, you have to get the patient's eyes checked because we know that ethambutol may have the effect of totally screwing around with the patient's color vision. So we check their eyes beforehand, make sure they don't have any color vision issues, and then we know if they do after we start the ethambutol that was from the medicine. And we use that medication with the other 3, and the mnemonic is right. And so you just want to know that the last page that I've included in this packet actually has very detailed information about each and every single one of these medications. Taking it on an empty stomach, taking it first thing in the morning, having your liver checked, liver function test checked, making sure you don't take PZA for more than 2 months, pushing fluids with the medicines, making sure you know that rifampin turns everything orange. All of that information is right in here. So you have it in there. It's 4 medications. The patient will be on these medications for 6 to 12 months, depending on how well they do. Now you know yourself, if you're honest, you probably have been prescribed antibiotics and not taken them perfectly. So a whole lot of encouragement has got to be given to this patient to please, 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 please again, take these medications as prescribed. They're gonna need reminders. Just think, your antibiotic lasted a week. They're on this crap for 6 to 12 months. Average is 9 months. So it's really kind of rough. Now, let's talk about this TB patient when they go home, because we don't keep them in the hospital the way we used to. While they're in the hospital, we know that active TB patients are under airborne precautions. You know what that means. That means keep the door closed. That means wear an N95 mask when you go in the room. That means that visitors are limited to a 30-minute visitor limitation. We know also that the patient will have a negative pressure room, so private room and negative pressure. Now, so that's airborne precautions, right? Well, when the patient goes home, we're not going to go through all those extraordinary measures, but we do say for the patient to make sure they have a room by themselves. If they can open the windows but keep the door closed, that is also really a good idea. When they are at home, they're not as contagious. So what we say about that is if someone comes over to visit them, not the patient, but the actual visitor must have on a, I'm sorry, not the visitor, but the patient must actually wear the mask. So what kind of mask do they wear? The patient must wear a surgical mask. And remember, that's the disposable one, so they need to put on a surgical mask. Also remember that the patient is told not to leave their home for any reason other than work. It's not like you could be out here gallivanting and all this kind of stuff. No, you need to only leave your house to go to work. And at that point, you have to wear a mask when you go to work. Okay, you can have visitors, but you have to put on a mask. The patient wears the mask, not the visitors. Okay, and then they must keep all their appointments. I will tell you this, when patients don't keep their appointments, we call everybody, try to find out where they are. If we can't find them, we send what? A certified letter to their house. If that certified letter comes back, I know this sounds crazy, but I want you to make sure you hear me. We call the County Board of Health and they put a warrant out for their arrest, because we cannot afford to have TB running rampant through our country, right? So this is so serious they will arrest you for missing appointments. So we have a TB clinic at Metro, and I saw it with my own eyes. So they are literally, a warrant is put out for their arrest if they're out there. We call it, the wording that we call it is lost to follow up. We've tried it all. We called your mama, sisters, brothers, cat. Don't nobody know where the hell you at. We just sent certified letters to your house and shit them came back, returned to addressee. I mean, you know, it's just ridiculous. So they got to find you, and they will put you away for this, okay? So TB is kind of hard. I suggest you really study it, because you can see some of it is very confusing, but hopefully you got something out of that. We're done.